Good evening, everyone. My name is Michelle. I'm a product specialist here at Oculus. Welcome to tonight's clinical webcast, Ortho K and Dry Eye, Getting the Most Out of Your OCULUS Keratograph 5M. You have a text box where you can enter questions. Feel free to enter your questions at any time, and we will discuss them at the end of tonight's webcast. Our speaker tonight is Dr. Thomas Weshefsky, a 1987 graduate of Pennsylvania College of Optometry. Dr. Weshefsky has specialized in contact lenses for over 3 decades. He earned his fellowship from the International Academy of Orthokeratology in 2009 and served on the board of directors of the American Academy of Orthokeratology and Myopia Control from 2009 to 2019. He is the former host of the Academy's Ortho K podcast series and has served as co-host of the annual Vision by Design Bootcamp for beginners and has lectured extensively on orthokeratology and myopia control to doctors from around the world. He has even been featured in several television news stories about orthokeratology, myopia control, and children's vision. Practicing in Myrtle Beach, South Carolina for the past 15 years, where he has built a successful Ortho K myopia control and specialty contacts lens practice, Dr. Weshefsky has recently added a thriving dry eye program to his practice. Welcome, Dr. Weshefsky.
Thanks a lot, Michelle, and good evening, everybody. I missed the days of live events, but this will be good. So tonight I'm going to talk to you about how I use the Keratograph 5M in my practice, and specifically for dry eye and Ortho K, and with Ortho K, I'm going to include myopia control. Arguably, those are the two hottest topics in all of optometry today. I mean, you can't even open up a journal without seeing multiple articles on both topics. The Oculus Keratograph can be your gateway into providing those services to your patients in your practice. And as I said, I'm going to talk to you about how I use it in my practice, and it'll help you to decide if these are the services that you want to add in your practice. I think it's important to understand why these topics have suddenly become so hot. And it's because they're going to apply to a very large percentage of your patients. Now, I've owned the Keratograph 5M for about a year and a half. And I have to say it's become the single most influential piece of equipment that I've ever purchased in my entire 33-year career. And that's pretty amazing. And it's a bold statement, especially when you consider the fact that I already had two other topographers in the practice. I have an autorefractor keratometer topographer, wavefront aberrometer as part of our refraction system. And I also have a 15-year-old topographer that I've used to design specialty lenses. And so the thought of adding a third topographer when, fewer than 1 out of every 4 practices even own a single topographer was kind of crazy. But I was convinced of the dry eye capabilities of the Keratograph, and that's really why I added it. The fact that I could also use it to design specialty contacts was just icing on the cake for me. So tonight I'm going to begin with why. Why would you want to use the Keratograph the way I do? I'm going to give you some historical perspectives. Next, I'm going to explain to you how I have implemented the Keratograph in my office, how I use it for dry eye screenings, how I use it for full dry eye workups, and how really the Keratograph 5M has caused a paradigm shift in the way that I view dry eye, the way I manage dry eye, and the way I treat my dry eye patients. Next, I'm going to show you exactly how I have implemented this, and I'm going to demonstrate it using the Keratograph. I will demonstrate exactly what I do to a patient in the room. I'll also show you how we use it to fit specialty lenses. And finally, I'm going to tell you exactly what impact this instrument has had on my practice. And I'm going to back up that bold statement that I began with. And of course, I'm happy to take your questions along the way. So with that, let's get started. And I'm going to go through these first few slides kind of quickly because they all make sense to you. This is nothing new to you. But why should you care? Let me get my PowerPoint running properly. So why should you care about dry eye? Well, the fact is that dry eye hurts. And the majority of your patients, certainly if they're over 40, are coming in, they have some dry eye symptoms. They may not always vocalize them because most people just assume this is a normal part of aging and they accept it as the way it's supposed to be. Well, it is a common part of aging, but it is certainly not a normal part of aging. These people are going uncared for. I mean, at best, they're just standing at CVS and grabbing different brands of artificial tears and really suffering. Why should you care about myopia? Well, myopia is a disease. It is the leading cause of visual impairment worldwide. We all know that it's reached epidemic proportions. We know that it increases someone's risk of retinal tears, retinal detachments, maculopathy, glaucoma, posterior subcapsular cataracts. And these two topics, they account for probably 3/4 of the people in your practice. You don't have to add a single additional patient to be able to provide these services. And I say myopia control because for most of us who do a lot of myopia control, Ortho K is the mainstay of our myopia control programs. Why should you care? Because your practice is under assault. With the increase in regulatory burdens, the never-ending cuts in managed care reimbursement, increasing competition from online retailers, our practices are under constant assault from every single angle. And why should you care? Because your bottom line is being affected. And all these factors that are affecting optometry today are eroding the pillars that support your practice and eroding practice revenues. So let's talk a little bit about the pillars that support your practice. And I'm going to get a little historical for a moment. And what pillars support your practice? Well, up until about 101 years ago, optometry had one pillar that supported it, and that was the sale of eyewear. That was true until about 1919, when a very courageous optometrist from Dallas named Fred Baker had the audacity to actually charge a patient for an eye exam. Now, the medical board had been waiting for this to happen. They promptly called the police. Dr. Baker was arrested, he was prosecuted, convicted, fined $500, and jailed for practicing medicine without a license. And thank God for Dr. Baker, because he appealed this case, and on appeal in the Texas Court of Appeals, about a year later, the ruling was overturned. Had that not occurred, optometry would be little more than a technician's position in an ophthalmologist's office. So we all owe Dr. Baker a great debt of gratitude, but thanks to him, we had a second pillar supporting practices, exam fees. Practice continued that way for quite some time, probably till the 50s, when contact lenses came on the scene. And here we're talking about PMMA lenses, old-time hard lenses. And so there are practices today that are still operating with just these three pillars. If we go forward a few more years, well, in my generation, when I first started in optometry school, the big fight was the medical model. You know, we wanted to be able to provide medical services, treat glaucoma, treat dry eye, treat red eyes. And that became the fourth pillar. And this is probably where the majority of practices are operating today. In my practice, early on, I decided to add specialty contacts. In those days, specialty contacts were mostly custom soft torics, the predecessor to Synergize, which was called the Saturn lens, which was the first lens that really worked well for keratoconus that was not an old-time hard lens. Ortho K was also something I added. we didn't know about myopia control those days, that the phrase didn't even exist. Well, we were performing myopia control just without being aware of it. Now, in my practice, over the course of my career, this is how I've grown. And specialty contacts and Ortho K myopia control have become the two largest pillars in my practice. My community has become largely a retirement community. And so Ortho K myopia control is probably not the best service to be, or the most applicable service that I could be offering patients. There was something I was missing, and we were treating some dry eye, but it was a very, very minor portion of the practice. So about 2 years ago, I made the decision to add dry eye, but it was a really tiny pillar. It didn't support much of anything. And the reason why I'm speaking to you tonight, because in the last 14 or 15 months, this is what's happened to my practice. Dry eye has just exploded, and it has totally changed the dynamic of the practice. And I'll get into the specifics of that in just a little bit. So let's talk about dry eye, and let's talk about it from an historical perspective. Historically, the approach to dry eye is to treat symptoms, all right? And we all know this. Prior to just the last year or two, that's all we ever treated with dry eye, and we were never very successful. You know, the modalities we had, we would use artificial tears. If that didn't work, well, we might try punctal plugs. If that didn't work, then we'd go to restasis. And the majority of our profession, the majority of ophthalmology, is still treating dry eye in exactly this way. Again, these are just methods of treating symptoms. No one is getting to the root cause. And how often does this work? I mean, in the days when we had live conferences, if a couple of ODs would get together and, you know, there's always be the comment, oh God, if I have to see another dry eye patient, I think I'm going to scream. Well, I got to tell you, I love seeing dry eye patients, but for a very different reason. You know, we're finally successful. So the symptoms are all we see, and that's all that ever gets treated. And I have to share this with you. I pulled this off of ODs on Facebook just a week or two ago. And it was a post by another doctor, very well-meaning, trying his best to help his patient out. And this is a laundry list of all the things that he has thrown at this patient, and he's asking for other recommendations. But he's treated, you know, if you look at this, he's treating an aqueous deficiency problem, he's treating blepharitis, he's treating a meibomian gland dysfunction issue, he's treating a neurotrophic disease. He doesn't really know what he's treating, and he's trying everything. And again, you got to give the guy credit for trying, but there's no rhyme or reason to what he's putting forward here. It's, you know, my advice to him was to go back and figure out what your true diagnosis is and figure out what your true cause is for all the issues your patient is experiencing. But we want to go beyond symptoms, and we want to get to the real problem and find those causes. All right, is it blepharitis? Is it MGD? Is it aqueous deficiency? Is it lid function problems? Is it neurotrophic disease? This is where the keratograph comes in. So this is what we're going to do. I am going to present a case to you. I'm going to treat you as though you were the patient. The words that are going to come out of my mouth are exactly what would happen in the exam room. I'm going to speak to you just exactly the way you are the patient in this example. So let me open up the keratograph software. And you are, in this example, this is for screening, we're going to do it. Oh, let me back up a bit. We screen every single patient that comes in for a comprehensive exam. I know there are those who don't agree with that. They think that the yield is too low, but I'm here to tell you that's what's worked very, very well for me. And the reason why we don't depend on symptoms, because again, as I said earlier, a lot of patients don't even think to voice their complaints because they just assume it's a normal part of aging, and there's nothing that you're going to be able to do about it anyhow, because they've spoken to a million other doctors in the past, and all they've ever gotten was a bottle of artificial tears. So let's take a look, and I'm going to do the screening. So the screenings are, as I said, just part of our normal exam. They come in for their annual exam, and my staff will run them through pretest, all the pretest procedures. We have added the keratograph to those pretest procedures. It's true it takes more time. It probably takes my techs 3 minutes, maybe 4 minutes to capture the data, to enter the patient's name into the keratograph software and then capture these images. And it, depending on what I see, it could take me 5 minutes more, or maybe even a little longer in the exam room. Sometimes it'll take me less than a minute. It really depends on what shows up on these images. So in this case, your patient, you're going to be the patient. Your name is Barbara. So Barbara, let's take a look at, we added a new instrument to our testing procedures, and we're just getting a lot more sophisticated, a lot more technology. So let's take a look at your tear film. And this will occur after I've already done their refraction, looked in their slit lamp, reviewed their retinal images with them. This is probably the last thing I do with them. So let's take a look at your tear film. The first thing we want to do is see the volume of tears in your eyes. Your lower eyelid acts like a dam holding a reservoir of tears back up against the eye. And I want to know how deep that reservoir is. So we measure it. And you can see here, here's your lower lid. And I'm going to measure the depth of this tear film. So your tear layer is about 0.28 millimeters deep. That's within the normal range. And the large majority of patients who have been diagnosed with dry eye have plenty of moisture in their eye. It's not lack of moisture, it's poor quality. But your tear quantity is just fine. We don't have any issues with it. And just as an aside, if you're kind of an astute observer, you'll see something looks kind of funny with these rings on this topographer. This is a post-RK patient. So you have plenty of tear volume. Let's check the quality of your tear film. When you blink, your lids come together, and when you open up, you're going to compress little glands at the base of your eyelid margin that will release tiny droplets of oil across the surface of your eye. This oil should be the consistency of olive oil. It should be very loose and clear, and it should spread out and coat the surface. And what it does, it floats on top of the layer of water, protects that layer of water from evaporating, and it lubricates the eye. What it should look like is an iridescent rainbow of reds and blues, kind of like gasoline floating on water or the surface of a soap bubble. It should look more like this. And you can see we have all this nice blue iridescence with a little bit of copper color. There can be a little red in there. This is a nice healthy tear layer. All right, this is a good lipid layer in the tear film. When I look at you, there is no color visible. And what we can see, and I'm going to slow this image down for you, we can see these little chunks. Okay, so you have a very poor quality oil layer in your tear film. The other thing we can see is all this crustiness along the lid margin and these blood vessels growing in. These are creating issues for you. Here we're looking for how red your eye is. And the instrument has looked at the white part of your eye and has measured how much red it sees and given us a number, all right, a numeric value to tell us exactly how red your eye is. Your redness score is 1.7. A normal healthy eye will have a redness score of anything from 0 to 0.5. So you're 3 times as red as we want you to be. Redness is a measure of inflammation. Now, usually it's from dry eye, but it can also be from allergy. Now, I talked about that oil a moment ago. Let's look at the glands that actually produce that oil. And this is infrared imaging. And these are those glands. And this is in your lower eyelid. And I'm going to compare these to some reference images that we have. This is you up here. And if we look down at this, down here to the lower left, you can see this is a normal, healthy set of glands. They should look like these nice, long, straight, finger-like projections. As we move to the right, they get progressively less healthy until we get down here, where many of the glands have died, and the few that are alive are really struggling. This is that person who's miserable. They have got that bottle of artificial tears in their hand and are putting drops in every 5 minutes. They are never comfortable. And this is you. Now we can slide this anywhere along this continuum. All right, clearly you're nowhere near as good as this. And you've lost a lot of tissue. You know, I'd say you're somewhere around here. Okay. So you have significant gland loss already. Now, I chose this case to present to you because this is a very, it's a substantial case. At this point, I'm going to stop. I'm not even going to review the left eye because it's really not necessary. I'm going to say to you, you know, let's just take a quick look at your left eye, and I'm going to go straight to the glands. And here you have, your glands are even worse. All right, I'm going to put you all the way down here. I really recommend that we get you back for a full dry eye evaluation. You have significant gland loss, and unless we do something to intervene, you're going to lose all the glands in the right eye as well as the left. And we need to do something to make you feel more comfortable and to protect those glands. So at that point, I would finish up my exam, and I'd have the technician escort you out to the optical if you were going to purchase eyewear. But at checkout, they would schedule you back for full dry eye evaluation. When you come in for your dry eye evaluation, I am going to go back, and they're going to repeat those 4 tests, but they're going to add a few. And I don't do all of the testing that the keratograph can do on my full dry eye workups because I don't really think it should take me as long as some of them would take to explain. And so let's open it up. I'll show you what I do. And again, there's a lot more imaging that can be done with this instrument, and I'll show you which ones I use, which ones I don't, and why I don't use them. So again, we're going to do, we're going to repeat the tear volume. So let's measure your tear volume, how much volume of liquid we have in the eye. And now you're probably about a 0.3. So again, within the normal range, you have a normal amount of tears. The next thing we want to do is see how quickly that tear film breaks down. Now, I'm not even going to go any further with this because her tear film breakup was just too quick to even measure. But when your lids come, the explanation I would give is, Barbara, your lids, when they come together and you blink and open up, your upper eyelid acts like a windshield wiper swiping across your windshield. Unlike a windshield wiper, it doesn't pull all the moisture away. It simply smooths out the layer of tears. That layer of tears is very, very thin, and eventually it's going to evaporate and break down. But in a normal, healthy tear film, it should stay stable on the eye for about 25 seconds or more. If it breaks down quicker than 10 seconds, those are patients who are usually pretty symptomatic. Well, her tear film is breaking down almost instantly, and you can see how watery it is. You can see also that there are some chunks floating in there, and that's probably why it's so short. It's almost instantaneous. This is non-invasive breakup time, by the way. So the next thing we're going to look at is the tear film itself, the oil layer. And this is kind of interesting. You can see a few things that I would go in deeper than I did with the screening. I'm going to slow this down. Notice that when you blink, watch what's happening. I'm going to leave my cursor on the screen. You don't blink fully. The lower half of your cornea is never getting re-wet. All right, this patient is an incomplete blinker. So when I stained her at the slit lamp, and I have a video slit lamp, indeed the lower third of her cornea was staining rather substantially. I'm going to stop it here. We can also see, when looking at the upper lid, you see this sort of whitish, yellowish haze. You can see this is blepharitis, okay? You can see the same thing in the lower lid. We can also see blood vessels, this vascularization in the lower lid. This is ocular rosacea, which is going to bring a lot of inflammation in. And again, we can look at the redness score, and you can see really clearly here, this is blepharitis. Lower lid, upper lid. It's kind of interesting. You'll see, you don't always have to see scurf. You don't have to see cylindrical dandruff. You don't have to see any of that to see blepharitis. If you think of blepharitis as a continuum, early on in the disease, you get this biofilm that builds up on the lid, and it'll give you this white, yellowish, creamy appearance along the lashes. And you may not see any particulate matter there. That doesn't mean they don't have blepharitis. I used to think of only blepharitis would be in those patients that had lots of that particulate matter. I've learned since that that's not the case. All right, that's a more advanced case of blepharitis. So again, your redness score is about the same as it was when we first measured you. You're still 3 to 4 times redder than we want you to be. That's just secondary to inflammation. Here we can look and see these blood vessels growing in. These are bringing inflammation into the eyelid. They don't belong there. And then ocular rosacea is a major cause of dry eye symptoms. Same thing in the upper lid. And again, we're looking at the meibomian glands. And again, I'll do the comparison. Now, typically the screening visit would be several weeks prior to this full dry eye workup. And so they may not always remember, but usually when you show them these images, and this was really the key to the keratograph, showing them the images and connecting the dots between their symptoms and the physical appearance of their eye is really the key. And so when you see a rapid breakup time, you say to the patient, when you look at something, it's clear for a moment, then it goes blurry, you blink and it clears up again, correct? And they're going to say, well, yeah. Well, that's because your tear film is breaking down, all right? So you would be the first one to validate their symptoms. When you see that there's lots of scurf, or you see that there's blepharitis, your eyes are crusty in the morning when you wake up, I tell them their symptoms. I don't always have to ask them. And the question always comes up about screening with a dry eye questionnaire. We use the OSDI, but I use it very differently than most practices. I don't review the results with the patient. My staff does the OSDI. I look at the score, and I'll look at which questions, are they having issues with wind, or with, what are their symptoms exactly? And I'll just use that as part of my presentation to the patient. I really use OSDI after we treat them, because when I see a patient back, let's say I'm doing IPL with the patient, and they're back for their second visit, and I walk into the room, I already know that their OSDI score is better because my staff has already done the OSDI again. They've repeated it. And so rather than walking into the room and asking the patient, so are you feeling better? I mean, I know I'm not curing them. There are always going to be symptoms there, but I'm making them feel much better, and I can quantify that with their score. So perhaps in this patient, she is an IPL patient. Her original OSDI score was 27. After her second IPL, her OSDI was 9. She's a very happy patient. By being able to pinpoint the root cause or causes and treating those causes exactly, you can make all the difference in the world. And that's what is really making patients happy. So let's move on from dry eye. Let's move on to specialty contact lenses. And as a topographer, you know, that's one thing you have to remember. This is at its heart a corneal topographer, and it's a damn good one. All right, it's very easy to use. It's totally repeatable. It's precise, and being a large diameter cone, you get a large working distance, about 3 or 4 inches, and so it's just a lot easier to use for a lot of patients. So here, this is an eye that topography has been done on, and all the data is down here at the bottom. You can see the K readings, the radius of curvature, axes, the total corneal astigmatism. There's some other measurements here that are really useful though, and you have to look through these numbers, but pupil diameter, if you're doing Ortho K or myopia control, you really want to know pupil diameter. It also tells you HVID, and this is very accurate. Horizontal visible iris diameter, they call it corneal diameter. This tells you about the offset from center, how far off the center of the pupil is, and this number here, this area, the total area indexed, this tells you how reliable the topography reading is. And anything over a 60 you can usually rely on. In this eye, I'd question this. I'd want to have this done again simply because these lashes are getting in the way, and that would make me question this reading here. But here we have the raw image and the axial curvature map. And you can look at axial curvature, you can look at tangential curvature, you can do an elevation map. You can even turn it into 3D if that's something you're into. This is impressive for patients, but you know, it's not something I typically use a lot. The other thing you can see really clearly is here. This is sagittal height difference at an 8mm cord. If you're an Ortho K fitter, you want to know how much difference there is at that 8mm cord in the flat meridian versus the steep meridian, because this will tell you whether you need a toric periphery in your contact lens. Now, I'm going to, and so this is something that you can use, anyone could use for contact lenses. But let's take it one step further. Kind of the hidden gem here is that about a year and a half ago, I believe, Oculus acquired Wave. Wave, for those of you who don't know, is a topographic design software platform for designing rigid contact lenses. And so let's say I wanted to fit a Wave lens on this patient. We come up here, click on Wave, and it opens the Wave software. And the software is designing a single vision spherical lens for this patient right now. And without me intervening at all, it has designed a single vision lens. It's going to ask me for the RX. And in this case, I believe the RX on this eye was -2.25, -50 at 165. And so that contact lens is now designed, and this will fit as well as anything you're going to get when you order it from your lab by calling in K's RX. It'll actually fit better because it's designed specifically for this eye. Now, you can go a lot further than just designing spherical RGP lenses. You can design corneosclerals, you could design multifocals, you can design torics, you can design bitorics, you can design full sclerals, you can design Ortho K. So I'm going to design an Ortho K mold for this eye. All right, now there's a definition list here, and this is the standard one that comes in the software. These are in there, and I'm just going to pick VST Ortho K mold. And it puts these pre-programmed parameters in, and you can create as many of these definitions as you'd like, but this is using standard VST design. And I'm going to design this in freeform. We can design it as a rotationally symmetrical lens, basically spherical. We can design it as a toric, geometrically symmetrical, or you can design it in freeform. Now, this eye doesn't really require freeform, but I'm just going to use it anyway. And the reason why I'd say it doesn't really require freeform is because the sagittal height difference from the flat meridian to the steep meridian is very, very minimal. The software is doing its thing. It's designing an Ortho K mold for this eye. And there's your final result. We can see here, this is a fluorescein simulation. I'm going to pump it up to make it a little more visible. And this looks like a pretty well fit Ortho K mold. I can change anything about this that I want. I can change the OZ size. If I wanted to make a myopia control lens, I would have a smaller OZ. I can change total diameter. I can change the power. This is 100% customizable. So that's how we would use it to design a contact lens. And I know we're running short on time, so I'm gonna get out of here. I hope I didn't go through that too fast for you. And let's come back to the PowerPoint. So let's talk about my 1-year results. All right, what has this done for my practice? Patient satisfaction has increased. You know, these dry eye patients, which we all always hated to see because they were always miserable, are now happy. They're thanking me. I'm getting better cataract surgery outcomes by improving the tear film. When we send the patient for the surgical consult, their biometry readings are far more consistent, and we're getting a higher number of patients, higher percentage of patients with 20/20 or better acuity. My practice gross has increased 19% in 1 year without adding any new patients. This is just using the patients, you know, my existing patient base. We've probably added a few. I haven't really publicized that we're doing all this. This is mostly in-house. When you treat dry eye patients, because this is fee for service, there is no managed care involved. Your net is about 80%, which means that my practice net, even though the gross has only gone up 19%, the practice net has gone up 60%. That's a substantial increase. What this has allowed me to do is add an associate. In fact, it made it necessary because dry eye now consumes probably 50% of my exam slots, maybe a little more actually. So between dry eye, specialty lenses, Ortho K, myopia control, I am 75 to 80% booked with those patients. I don't really do very much in the way of primary care anymore. It's allowed me to reduce my schedule from 5 days a week to 4, which is really nice. So the tips I would have for you when it comes to dry eye: treat dry eye before you do a cataract consult. The results will just be far better. Your surgeons will love you for it because their results are going to come out so much better. You're going to make them look good. Far fewer post-op problems as well. Screen everyone, and I mean everyone. There's a question as to whether or not you should even be screening children. Duke Eye Medical Center has done a study just not too long ago. An ophthalmologist by the name of Priya Gupta published a study in looking at the prevalence of meibomian gland atrophy in the pediatric population. And in children between the ages of 4 and 17, she's found that 42% of them had some level of meibomian gland atrophy. And the study was interesting. It creates more questions than it does answers. It just really, are these the ones that are going on to look like this patient I just showed you with no meibomian glands left at all by the time they are 70 years old? Bring them back for full dry eye evaluations. I don't make those diagnoses on the day of their standard eye exam. We bring them back and we go further. Now, I don't just do the keratograph when I bring them back. I'm also looking at them at the slit lamp. I'm also using a meibomian gland evaluator to put a sufficient amount of pressure to try and see what comes out of those glands. You have a video slit lamp, so I video that and show it to the patient. And if I think they need to be stained, I'll stain them. You can do staining in the keratograph. If you're the one doing the procedure, I think that's great. It has capabilities of measuring breakup time with fluorescein. You can image for fluorescein staining. You can image for lissamine green staining. I just prefer to do those things at the slit lamp. Schedule any needed treatment for another date. You want to keep your schedule flowing, all right? So these patients do take more time because there's a lot of talking, it's a lot of education. And it's show and tell, and let their images do the talking. Forget the sales pitch. All right, I've had several other docs ask me about, well, how do you close this? How do you get them to say yes to LipiFlow or IPL or tear care or whatever the treatment modality is, because they're all out of pocket and they tend to be on the expensive side. I don't try and sell anything. I educate the patient. I connect the dots for them. I show them their images, explain how their symptoms relate to each image, and let them see it for themselves. And I've got to tell you, they are the two images that freak them out the most are the meibomian glands and the redness score. They don't like red eyes, especially ladies. You also have to advise them that dry eye is a chronic disease. You're not going to cure them, all right? This is going to need treatment ongoing. And don't promise the moon. I tell my patients all the time, look, I'm not promising you rainbows and flying pink unicorns, but I am telling you we can help protect your gland function, and the majority of this is really meibomian gland dystrophy and meibomian gland disease. When it comes to Ortho K, number one, always get killer pre-fit maps. You only get one shot at a virgin cornea, all right? You need excellent maps because anything you do after that is going to rely on that first set of maps that you took. The axial sagittal curvature maps show power shifts. Tangential curvature maps show where the mold is sitting overnight. You may not always need to put fluorescein in and look at the fluorescein pattern with the mold, because where it sits overnight is going to be shown by this tangential map, and that's what really matters, not how the mold looks on an open eye in your exam chair. There are compare functions to show the changes, and I apologize I didn't show you those. I realized I was running short on time. Learn to use the WAVE platform. Once you learn WAVE, there is the things that you thought were impossible before now become part of your everyday reality. The power of that platform to design an individual lens for an individual eyeball is just incredible. So with that, I will take any questions. And again, I apologize for running long.
All right. Thank you, Dr. Weshefsky. Just a reminder, on your GoToWebinar screen, there is a text box where you can enter any questions that you may have. If you missed part of the webinar, or if you want to go back and review part of it, you will receive a link to the recording in the next week. All right, we do have a couple questions, so I will go ahead and start to read those off. When you're referring to the chunks visible in the interferometry, are they the same as particles in the tear film dynamic?
No, they are not. Well, they'll still appear as particles in the tear film dynamic. I really think what happens is that meibum, which should come out nice and loose and clear, starts to thicken. And, you know, if you've ever expressed glands, you'll see particles coming out. You'll see pus coming out, and you'll see all these little particles in the interferometry. That's just thickened meibum.
Okay. All right. How long does it take to adequately improve the tear film prior to cataract surgery? Are you telling patients that we'll schedule you for cataract surgery 3 months out from now after we've addressed your dry eye symptoms?
Well, it really depends on how bad they are. So if it was a patient like that last one, she's going to be at least 3 or 4 months out, because with so much inflammation in those glands, on that patient, I'm definitely going to want to do IPL. And I don't know that that alone is going to be enough. I mean, when there's so much gland loss, you're trying to maximize what little she has left, and you have to hope. And in her case, I will end up everting her upper lids and looking at the glands in the upper lids. I don't have my techs do that routinely. They don't like doing it. It takes them a long time. And so I'll do that. But there's really not much in the way of gland structure in that patient. If it's gland structure that's still there, and I think that it's just blepharitis and maybe just some thickened meibum, you know, in a case like that, we're going to do something like Blefx and follow that immediately with some heating and expression, whether it's tear care or LipiFlow, or if they have MibaFlow, one of those. So it really depends on the individual patient, where on that spectrum, how severe their dry eye issues are.
Okay. All right. You had talked about looking at children possibly for dry eye. We did have someone who was asking, do you test children for dry? If so, how often do you find dry eye symptoms in children of various ages?
So we routinely screen every single adult, but we don't routinely screen every single child. And if the child is symptomatic, if they're coming in complaining, yeah, we're going to screen them. And it's difficult with children because you can't do a lot of the same things you can do in an adult. All right, most of the treatments don't really apply to children. You know, for instance, you really have no business doing IPL on a 10-year-old. All right, it's just not appropriate. You know, it's far more difficult in children. Usually they're not as symptomatic, but these days, you know, COVID and mask eye and all the associated problems, we're seeing more of them. And so it's always startling to me when if we do screen a child and say that they've got significant gland loss. I mean, I've seen children that look as bad as that 70-year-old I showed in the demonstration.
All right.
Tough to know what to do with them.
Yeah. Do you utilize the questionnaire during the crystal tear report assessment or at a separate time during the exams?
So my techs do that prior to me seeing the patient. And the information is up on the screen for me to see. I don't, as I said, I don't review it with the patient. It really is a way of me sort of setting the tone for the conversation. When I walk into the room, I've already seen their chart, and I know what their original OSDI was. And let's say they're coming back for their second or third IPL, and I see that their OSDI has improved tremendously. I'm going to come in and say, wow, Michelle, you're doing really great. Your score went from 32 down to 7. And that those kind of things do happen, and actually far more often than I ever expected that it would.
Okay. All right. After IPL or LipiFlow treatments, do you at some point image the glands again during your dry eye follow-ups to compare the gland imaging prior to the treatments?
Yes.
And do you notice less loss of the tissue or improvement in the appearance of the glands?
No, I don't notice any real improvement in the appearance of the glands usually. That's kind of interesting. I'll see that their symptoms have abated. They feel much better, but the images don't necessarily look tremendously better. You'll see some improvement. They'll be brighter. I mean, realize that, you know, if the tissue is dead, it's dead. You're not going to resurrect dead tissue. You can rehabilitate sick tissue, but we don't see as much improvement in the physical structure or the physical appearance of the glands as I would have hoped. But the patients are feeling better. So I'm happy at that point, as long as they're happy. And yes, I do image them. Typically, we'll check them again at 6 months.
Okay. As we have someone who's asking, which video slit lamp are you using?
I have 2. I've got a much older system that was it's a Huvit system. It doesn't work as well. But it's also was a lower end system. I also have a Telscreen, which is in my the lane that I primarily use, and it's just something I've had for a very long time. If I didn't have it, I don't think I would purchase one today. I think I would just continue to use the Keratograph. But since I already had that existing capability, that's one of the reasons why I don't do everything within the Keratograph.
Okay.
But the magic really of the Keratograph is being able to pull up all those images one right after another in a very concise, clear, cogent fashion, and you can tell the story. And I spent too much time trying to explain what I was doing. I should have just told the story. That's what I originally set out to do. So it comes out a lot smoother when I'm with a patient because I'm not trying to explain how I'm doing it.
Okay. Are there any other tests that you do in addition with the Keratograph, either for your screening or your follow-up or your full workup, that the Keratograph doesn't do that you do in addition to?
Sure. As I said, I express glands using the Meibomian gland evaluator. I could have brought one in the room. I don't have it. It's produced by is it Sight Sciences or J&J? You can, and it's relatively inexpensive. It's a little device, a handheld, that is spring-loaded and will produce the equivalent amount of force from a very forceful blink to see what comes out. And because you can just press with your thumb and that works, but how hard are you pressing is you don't really know. You're more than likely going to press harder than lids would normally blink. But this device is calibrated to be equivalent to the force of a very hard blink. So I do that. I will do staining. You know, I haven't found the need for doing MMP9 or osmolarity because I don't know that they're going to change the outcome. I don't think they're going to change what I'm going to recommend. they're nice. They're nice to have. If you have it, I would certainly use it. But you know, I went kind of crazy on dry eye. My initial investment in dry eye was over $100,000 before I had a dry eye program. I just was really confident, knowing that I have such a large population of baby boomers in my practice, that I kind of just on faith just knew that I was going to be able to do this. But if I thought those would make any big difference in my treatments, I would probably use them. But as of now, I haven't found the need.
All right, thank you. How often do you need to revise the fit of an Ortho K lens that you've designed with Wave?
How often? Most of the time, we're pretty much right on the first set. I don't think I have a percentage that I can give you. The biggest reason to refit an Ortho K mold is decentration. And when you're just calling in Ks and RX, if the cornea was like that topography that I showed you with a very small elevation difference at that 8 millimeter cord, you could fit pretty much any Ortho K mold on that eye, and it's probably going to center reasonably well. But that's not your average cornea. Usually there's going to be a lot more disparity in elevation differences at that 8 millimeter cord. And if there's any kind of asymmetry at that 8 millimeter cord, you're going to get a lot of decentration. But because Wave is based on the topography of that individual eye, I liken it to getting a bespoke suit as opposed to buying one off the rack. It's just going to fit a lot better.
Okay. All right, thank you. And do you automatically do gland expression after IPL or LipiFlow treatments?
I never do gland expression after IPL. Because the glands have cooled down by the time you get them cleaned up and in front of the slit lamp. I don't really, IPL is a great system for quelling inflammation. It is not a great system for heating the glands. And, that I would rely on either LipiFlow or tear care for. I sometimes will do expression after LipiFlow, but generally, again, by the time you get the device off them, and I don't do LipiFlow in the exam lane, I have a spa room basically for dry eye treatment, and I do LipiFlow in there, I do IPL in there. Everything else I do in an exam chair. And so getting the patient to a slit lamp, by the time they walk down the hall into another room, those glands have cooled off. And anyone who's done tear care with any regularity will know that as soon as you remove that device from the eye, it's starting to cool down, and within a minute, it gets a lot more difficult to express those glands.
All right. Okay. Thank you. And thank you, Dr. Weshefsky, for that great presentation. And that's all the time we have for tonight. And thank you, everyone who sent in questions. And thanks for everyone for joining us. And thank you again, Dr. Weshefsky. Is there any last words you would like to leave the audience with?
Just want to thank everyone for showing up tonight. I know it's a work night and it's kind of late here on the East Coast. And thank Oculus for the opportunity. I enjoyed it. And we'll see you again.
Yeah, thank you. And this concludes our presentation. And on behalf of Oculus, have a good night, everyone.
Thank you. Good night.
Thank you.